Thanks, Nick, and thanks all of you, and thanks for the invitation of talking about some of the work that we did back in 2011, 2010, 2012, sometime around then. Memory fades with time. This is NILS Project 33, and I'm indebted to contributions from Claire Telford, whose PhD was actually built around this, Michael Donaldson and Donald O'Carrollin, who are heavily involved in oral healthcare in Northern Ireland from a policy perspective, and Liam Murray, who was a co-supervisor of the PhD. The PhD study was basically around equity in the use of dental services by children and adults, and you'll see for reasons which will become apparent why NILS was so important for the conduct of this. I'm putting this disclaimer at the front because if I tend to extemporise, I think it's important that I get out of the way, that any comments are attributable to me rather than any of the other individuals involved. But I would obviously like to thank NILS support team and also the funders of the NILS support team for their contributions and the work which has been made possible as a result of that. So the background to this study. The background to this study is really one about healthcare needs and one about expenditures on healthcare, expenditures on meeting those needs. And for those of you who are unfamiliar with oral healthcare and how it's actually provided, which I imagine is the majority of the audience, oral healthcare involves three key players here in Northern Ireland in terms of providing services. You have the general dental practitioners, you have the community dental service, and you have the hospital dental services. By far, the bulk of oral healthcare is actually delivered by GDPs, general dental practitioners. Those are the dentists that you will encounter in the high street. Total expenditure on oral healthcare approximately each year is around £150 million, which is not an inconsiderable amount of money. And it may interest you to know that the bulk of that continues to be made up of public expenditure. So around £130 million each year is spent on oral healthcare in Northern Ireland. The bulk of that is in turn, in actual fact, associated with consumption of care by children and adolescents for whom the state continues to provide publicly funded care based upon need, free at the point of delivery. In terms of oral health, at the time that we were launching this study, or undertaking this study, all of the indicators were that oral health in Northern Ireland was among the worst of the British Isles. So not only is caries the most common disease, dental decay, the most common disease of childhood, in Northern Ireland we had perhaps the worst that existed not just on the island of Ireland, but in the British Isles. So 61% of 5-year-olds were affected by decay, according to the Child Dental Health Survey in 2003. And by the time that they got to the age of 15, around 78% were in actual fact showing evidence of obvious decay. So for reasons both of fiscal responsibility in terms of the amount of money that we're actually spending on oral healthcare, and because of the manifest oral healthcare needs that we have, needs which, as the slide goes on to say, evidence a significant socio-economic gradient, it's important that we in actual fact look at oral healthcare and whether or not our current manner of funding services and our current way of meeting needs is actually fit for purpose. So for both fiscal and for health reasons, maximising health gain, this was an important study to undertake. NILS, I think, as the other speakers have already alluded to, provided a unique opportunity to in actual fact do this work and to do it in an efficient manner. So what we were able to do with NILS that we wouldn't have been able to do with survey work or using other data sources was to actually track people's use over a number of years and relate that to a rich socio-demographic characterization of those individuals. So oral healthcare, like many aspects of healthcare, is difficult to grasp if you're looking at it within the context of a snapshot, maybe over the course of a year, because courses of treatment may in actual fact last much longer than 1 year. And here what we were looking at was courses of treatment which could have been delivered over the course of 4 or 5 years. And with my economist hat on, the importance of the efficiency that NILS brings to bear, I think is one which is important to allude to, as other speakers have already done. So the study aims here, well, primarily there were two. What we wanted to do was to look at differences in registration. So in order to consume publicly funded oral healthcare, you have to be registered with an NHS dentist, one of those GDP dentists. And that registration has to exist for a particular period, there has to be use within a particular period of time for that registration to remain live. So we were interested in patterns of registration and breaks in registration. And then also what we were interested in was the patterns of service use. Dentistry isn't simply about drilling and filling, though some people might think that that's what in actual fact GDPs, general dental practitioners, do. A lot of work is also involved in the provision of prevention, in the provision of orthodontic services, as well as drilling and filling. So we want to look at the services, at the pattern of service provision, relate both registration, breaks in registration, and patterns of service use to the socio-demographic characteristics of the individuals consuming that care, and do that over a period of time. What we were interested in doing was then to interpret that evidence through the prism of economics and see whether or not it was an issue of preferences on the part of the consumers, or whether or not it was an issue of incentives on the part of general practitioners, which were going to influence what we were seeing happening. The methods were relatively straightforward. Once you get over the hurdle of getting your NILS data in a usable format, the methods, as I say, are relatively straightforward. So what we had were roughly 15,000 potential observations, of which, because of some attrition related to people leaving Northern Ireland, we ended up with roughly 13,000 observations. The individuals that we're looking at were individuals who were aged 11 to 12 in 2003, and what we were doing was to track them through to 2007, 2008 in terms of their use of care. So we were able to look at patterns of service use, but also how patterns of service use changed over time. The methodological approach involved largely a set of multiple regression analyses of different pieces of data. So we looked at expenditures by service type, we looked at the duration of registration and related that to socioeconomic status, breaks in registration, again related to socioeconomic status, expenditure and expenditure by service type, again related to socioeconomic status. And then the last thing that we did, because it makes for an interesting graphic, as well as providing insights in and of itself, was to look at concentration indices. Now, the concentration index basically provides an indication whether or not there is disproportionate use of a particular service relative to that group's presence in the population. And as you'll see in the slides, as I say, it does provide a nice graphic. It's bounded between -1 and +1, where as you move from 0 to +1, it indicates a pro-rich pattern of service utilisation, and as it moves from 0 to -1, a pro-poor pattern of service utilisation. This is a very busy slide. I don't know whether or not you can see any of it, but what I've done is to highlight some figures in it, and I'll move over towards the slide if you bear with me to draw your attention to them. If I focus in on the multivariate analysis, what we're looking at here is how many months children were registered with NHS dentists during the course of the study period. And what we're looking at here is socioeconomic status by the standard socioeconomic groups: professional, intermediate, self-employed, down to never worked, long-term unemployed. Below that then we have education, where we have degree and above as our base category, down to no qualifications as our one of our lower socioeconomic groups. And here we have gender, here we have married, cohabiting, lone parent. I'm not going to focus on the marital status ones, but rather focus on the socioeconomic status measured in terms of these groups as well as education. And the results can be summarised very easily by saying that those who are of lower socioeconomic status, whether it's in terms of these groups or in terms of education, have significantly less periods of registration with NHS dentists relative to those who are either better educated or better off in terms of their socioeconomic group. In this slide, we're looking at the exact same thing, albeit in a slightly different fashion. So here we're looking at breaks in registration. Again, I'll focus on the multivariate analysis, and again, the results can be summarised very easily by saying that if you are from a less well-off group, or if you are from a less well-educated group, you have significantly more, statistically significantly more breaks in your registration than is the case for those who are either better off or those who are better educated. I have said that I will not talk about these marital status groups, but they fall in basically with the results that I've already alluded to. So if you're from a lone parent family, or if you're from a cohabiting family, you have more breaks in registration, as well as a lower period of registration. Well, if the last slide was busy, this one's even busier. What we have here are those covariates, and what I'm relating those covariates to are total expenditures on NHS dentistry, and then looking at patterns of service use across the different types of service provided. So orthodontic, extractions, restorative, that's accumulation of drill and fill, fillings, and endodontics. Endodontics are root canal work, so the extreme end of dealing with tooth decay. And the patterns are obvious, albeit perhaps not from this slide, from the distance that you're sitting. If you are among the lower socioeconomic groups, you have significantly less total consumption of dental care, but that is largely attributable to orthodontic work. So other groups are consuming much more orthodontic work than those who are less well off. Whereas if you look at restorative work, whether it be in terms of overall restorative work, drills and fills, that's where you see, in actual fact, additional utilisation of services by those who are less well off. I'm not going to go through these additional results, but it is just that there are a number of other covariates that we looked at, which in actual fact came through in a manner consistent with what we were expecting to be the case. The concentration index then sort of throws this into sharp relief. What we're looking at here are the different types of service and the pro-poor or pro-rich patterns of utilisation associated with those. It's fairly obvious from this slide that orthodontics is pro-rich in terms of the pattern of utilisation. Overall expenditure is pro-rich in terms of patterns of utilisation. Registration is pro-rich in terms of patterns of utilisation, whereas this drill and fill, dealing with tooth decay, is much more pro-poor in terms of patterns of utilisation. And we think that this cannot be divorced from both the behaviours of the individuals involved and also, however, the incentives that are presented to general dental practitioners to meet the needs of groups. At the time that this work was being done in Northern Ireland, roughly about 60% of NHS expenditures on this group were related to orthodontics. So you're straightening the teeth of relatively well-off people. And at the time that this work was done, there was no measure which was used, which was in place to relate the provision of service to the need for that service. Something which, again, is important to bear in mind. So our conclusions from this study: dental registration was lower among lower socioeconomic groups, and it was more fragmented. The intensity of dental service usage, by which I'm really talking about the expenditure, was lower amongst those from lower socioeconomic groups. Higher social classes had higher average expenditures, but that's particularly related to orthodontics, but lower average expenditure on extractions and conservative treatment, restorative treatment. Broader conclusions then in relation to NILS: it afforded valuable insights into the role of economic variables and patterns of registration. There were significant differences in patterns of registration and use that we could interpret then by reference to our economic models, reference to things like preferences, rate of time preference, target income hypothesis, all the standard things that economists like to talk about. But also then there is this notion that the manner of healthcare funding may contribute to patterns of utilisation, and at that time we thought warranted examination. Now we were in a very, I have about 1 minute I think left, so we were in a very fortunate position in that whenever we were doing this work, the dental contract was under renegotiation. So they were looking at all of these issues again. The dental contract has changed, and the things that the NHS dentistry is now funded to do in Northern Ireland has changed as a result of that. So, if I can say, reasons to be cheerful. I used to be an Ian Drury fan. So, reasons to be cheerful, part one. The pattern of decay has changed dramatically in Northern Ireland over time. So, this is the results from the Children's Dental Health Survey. And you can see the big drop here in the percentage of 5-year-olds who are exhibiting patterns of decay. Much lower than was the case, and cannot be divorced from the efforts that have went into expanding access and incentivising prevention over actual treatment. Reasons to be cheerful, part two. The introduction of an IOTN score a measure which is used to assess treatment need. So now resources are focused on those who, in actual fact, meet an objective measure of need, rather than it being left to a negotiation between the parent, typically, and the dentist as to whether or not a child should receive access to publicly funded orthodontic care. So now orthodontics is formally related to an objective measure. And I think it's not an accident that we have in actual fact seen public expenditures on orthodontic care reduced as a result. Now, you may not think that these figures are dramatic, but try and actually contain healthcare expenditure in any area, and a reduction, even though it might seem modest, is nevertheless notable. And then just one last thing, the reason to be cheerful part 3, the work is ongoing, but what I would expect to find whenever we're looking at this again is that the socioeconomic gradient, which is currently under investigation, will in actual fact have reduced, not just in orthodontic care, but across the other different areas of care as well. So,
thank you very much, Ciaran.